Hello class, my name is Charles Blanchard. I'm actually going to be discussing the value of HIEI, and I actually want to take the time to go ahead and discuss the definition or the acronym of HIEI. HIEI is actually an acronym for Health Information Exchange and Interoperability. This is actually the ability to exchange information between the providers of the same level of interoperability. Basically, this is actually being able to communicate between different organizations and different software systems, regardless of the level of software data that's being exchanged. Oftentimes, we would define stakeholders including laboratories, pharmacies, payers, radiology centers, and public health departments. I'm sure we've all actually had the experience of having our orders sent over for lab work or pharmacy, and having the ability of not having to take a paper lab order or take a paper prescription all the time, and being able to exchange that information electronically will allow different experiences and a more streamlined experience for not only the provider but the patient. My article actually takes the time to create a proposition and how this can be implemented, and at the time they went ahead and created a conceptual taxonomy in which they actually broke down the health information exchange into 4 different levels. Level 1 including the non-electronic exchange of health information, and this would actually be through mail or phone. And I like to consider that level the dinosaur age, so the old ways of doing things. Level 2 is actually the non-standardized information exchange of information through basic information technology, and this will include fax, pictures, PDF, or other scanned items that cannot be manipulated. Level 3 includes machine organizable data, and this includes email, which is written in free form, or PC-based exchange files, or HL7 messages. And these actually include different vocabulary and using different interfaces between different organizations. And sometimes there can be some imperfections in the level of detail, as one organization may use a different terminology than another one, and create some translation conflicts. Level 4 is actually the highest level and most ideal, which is actually machine interpretable data, which actually shows automated code exchange from lab to EMR. This will actually allow the exchange of information between different organizations at different software levels, and being able to minimize errors and vocabulary differences, and being able to cross integrate those. Based on the conceptual proposition, the article actually breaks down the benefits into 2 different categories, which include qualitative benefits. Qualitative benefits show reducing redundant tests and prescription therapy, reducing delays and cost in the exchange of prescriptions or orders, or tracking down medical records, as that can be lengthy in time and take multiple parties involved and more cost. It also helps reduce errors. As we've learned earlier in the semester, there are a lot of errors that can take place in exchanging paper-based information or records, as it also is a matter of trying to interpret handwritten data, or actually transcription of audio, and minimizing that, or actually converting it into electronic form. And health information exchange helps reduce those errors. It also creates a more streamlined process between for the treatment of a patient between different providers, and reducing a fragmentation of care, and essentially it provides convenience for both the patient and the provider. The other benefits can actually be deemed as quantitative, which actually include estimating approximately $2.71 billion over the course of 10 years in the reduction of phone calls related to medications or prescriptions, physicians having to take the time to order or put in the prescription for a patient, or pharmacies having to follow up on refills and so forth. So it actually is projected to have that amount of savings, and as well as provider-to-provider connectivity to obtain medical records or referrals is estimated to have $13.2 billion in savings over the course of 10 years. Again, this is based off of the proposition in my article. It's not anything that's necessarily factually backed up, but the quantitative benefits also include being able to early detect developing disease outbreaks. Essentially, it'll allow the compilation of data across different organizations and being able to track that data, whereas before you wouldn't be able to track it as efficiently, and it may take a little bit longer to identify different outbreaks. Having the interoperability or being able to communicate between different organizations would increase the efficiency of that. So my article then goes into what it proposes to be the rollout, and the rollout would again take the course of 10 years to fully recoup the investment of rolling out the Health Information Exchange. And they propose that the first 5 years, approximately 20% of the organizations would install the systems nationwide. They would have 50% potential benefits in the first year, and then 10% each subsequent year thereafter. As previously discussed, we went over the different levels of Health Information Exchange, and just focusing on the upper levels, level 2, there's a net value of $21.6 billion over the course of 10 years, $23.9 billion for level 3 over the course of 10 years, and as you'll see, the highest benefits is actually the level 4 at $77.8 billion over the course of 10 years for the implementation of Health Information Exchange and interoperability. So some of the limitations of my article was that there was a lack of statistical information at the time that my article was written, which was back in 2005, and a lot of the data or proposition was based off of having expert reviews or interviews and projections based off of that information. It also doesn't take into account workflow disruption, which, as we all know, whenever productivity slows down, then the costs go up. So having that disruption of workflow or having those changes and how long it takes to acclimate to those changes can affect what the workflow is, and takes a little bit more time to recoup the implementation of Health Information Exchange. So this also creates incentives or conflicts and incentives to adopt the Health Information Exchange, as some organizations may reap less benefits from the implementation and inconsistency in the level in which an organization can implement, and delaying interoperability depending on what level that organizations actually roll out. So this moves to the idea of, is there really value in Health Information Exchange? One example or article that I found that was more recent from 2015 shows, I guess, a sampling of approximately 15,645 adults in New York that visited an emergency department over the course of a 6-month period. Not the same patients, but just a snapshot. And of these, 2.4% of them were entered into the Health Information Exchange system that was established in New York at the time, which showed a 30% reduction in utilizing that system, and approximately annual savings of $357,000. So if we take that into context and think about how much money would be saved if this was rolled out nationally across the billions of patients that are actually seen annually, then we can only begin to realize how much money could be really made, or benefits really made in rolling this out. Of course, there are costs involved, which takes time to recoup, but as projected in the article, the organizations, regardless of the level, would theoretically recoup those starting in year 11. So, in conclusion, including the article and some other articles I found, it's current day, it's still a long process. We still have a long ways to go, and will involve some probably incentives from federal or state levels to help support the implementation of health information exchange, and motivation to try and have a more consistent level of implementation. So I hope you enjoyed, and thank you for watching.